Hello, I would like to welcome every one of you to the session of liver transplantation. For assessing the recipient liver, first of all, a bilateral subcostal incision is made, and if necessary, the incision is extended to the Xiphoid process, giving a Mercedes sign to the incision. Then, a Thompson retractor system is used to elevate the lower costal margin. Now, we move into the dissection of the structures in the free edge of the lesser omentum leading to the porta hepatis. The common bile duct is first ligated and then divided as close as possible to the porta hepatis. Then, the common hepatic artery and portal vein are dissected and controlled with the rubber slings. The infra-hepatic portion of the inferior vena cava is dissected above the renal veins, and the possible hemorrhage is controlled with the help of a nylon tape. Then the peritoneal attachments of the liver are dissected, starting with the left triangular ligament and proceeding to the falciform ligament, thus exposing the anterior surface of the suprahepatic portion of the inferior vena cava. Progressively, the liver is dislocated from the hepatic fossa while it is dissected from the bare area of the diaphragm. The retrohepatic portion of the inferior vena cava is completely mobilized from the posterior abdominal wall, and subsequently the right adrenal vein is ligated and divided from the vena cava. Vascular clamps are applied to the vascular connections of the liver, and then the liver is excised from the body. Now, for the replacement with the donor's liver, we begin the reimplantation with the suprahepatic venacaval anastomosis followed by infrahepatic venacaval anastomosis. Then, the donor and recipient portal veins are anastomosed end to end. With completion of the anastomosis, the clamps are removed from the intrahepatic vena cava, followed by suprahepatic vena cava, and finally from the portal vein, so that the new graft receives the portal venous blood first. An end-to-end anastomosis is made between the donor and recipient common hepatic arteries, and the biliary tract is reconstructed as an end-to-end duct-to-duct anastomosis. Following this, a donor's cholecystectomy is done and a liver biopsy is taken. Finally, the surgical site is checked thoroughly for hemostasis, and all vascular anastomoses are inspected for possible hemorrhage, and extra sutures are added when necessary. So is the case with biliary duct anastomosis. In this way, the donor's liver is transplanted into the recipient body. Following transplantation, the abdomen is sutured back into the original position, and the patient is transferred into the intensive care unit where ventilation is continued until the patient's cardiovascular condition is stable. In this way, we come to the end of the liver transplantation session. Thank you.